Liana? What is Liana? Where is Liana? Liana, how about Liana? Okay, the first question I'm going to pose is to Liana. Okay, start.
Good afternoon. We have all gathered here today to talk about asthma, case review and discussion. So this is a 14 years old Malay female. She's immunized. Her weight is a 55.7 kilogram. She's got underlying bronchial asthma and diagnosed since 9 years old, along with allergic rhinitis and also conjunctivitis. She has MDI salbutamol 200 mic PRN, and also prior to exercise, and also MDI serotype 2 puffs BD. She had a recent admission in July 2023 for acute exacerbation of bronchial asthma and bronchiectasis, secondary to human rhinovirus and enterovirus. There was history of intubation for 2 days in PICU during that admission in July 2023. So it tells us that she has a brittle or severe asthma, since she can deteriorate very fast to a point where she needs intubation. Although she had COVID-19 bronchiectasis since 13 years old, she's on net 5% saline TDS with airway clearance at home. Her latest IgE is 1,283 in July 2023. So it shows us that there is a allergic component is related to asthma. So this time she came in with the usual typical symptoms. She had cough and runny nose for 2 days. She was chesty with green phlegm. Shortness of breath for 1 day, sudden onset while resting in bed. Initially, she tried her 2-puff PRN, but subsequently she had to increase to, according to the asthma action plan, 8-puff 4 hourly. She also experienced chest tightness for 1 day on that same morning, especially during inspiration. There is exposure to rain, which could have triggered it. So she presented to Klinik Kesihatan at 3 p.m. on that same day, treated as acute exacerbation secondary to URTI. She was given NAP VAN back-to-back ×3 and IV hydrocort 200 mg stat. She was put on face mask 5 liter per minute and sent to ED PPUM. In ED PPUM at 7 p.m. she arrived. She was still speaking in sentences. RR was 20. Aspiratory on room air was 94%. Her heart rate was 140 beats per minute. BP was 108/65, and her temperature was 36.4. Lung findings were scattered bronchi with recessions. At that time, we treated as moderate AEBA secondary to URTI, given again NAP ABN stat dose and another dose of IV hydrocort 100 mg TDS, 100 mg stat and TDS. Admitted to ward 8 PB at 12 a.m. with MDI salbutamol 12 puff 2 hourly, and also MDI brodeuel 4 puff 4 hourly.
Okay, so at this point, so I'm going to ask Roshini first. Okay, so I want you all to maybe each one of you all tell me what are the issues and the problems. Clearly, this was a very well-managed case. I would be discussing it here. Okay, so what have you noticed in this? Just give me one thing. What is the issue and the problem? If you are the doctor at A and E, what would your problem be first?
The saturation was 94. That shows me it's already
Under?
Because the recession also, so it's already moderate exacerbation.
Yeah, so this one is moderate exacerbation of bronchial asthma. So this is actually correct. Okay, correct. Yes.
The management one, maybe I would prefer to give a NAP Ventolin, maybe 1 cycle first instead of just giving an ABN stat in ED. I'll give like 1 cycle of Ventolin and then reassess back after 1 hour.
So your choice would be is that instead of using nebulizer, you want to use MDI, is it? Or what's
like here.
Which one do you want to use?
No, I will give MDI salbutamol 1 cycle. That means for her would be 12 puff.
Okay.
12 puff.
Okay.
Every 15 minutes.
Okay. Times 3 lah.
Times 3 yes, 1 cycle.
Okay. Okay. Anything else that you think? Anything else? Next girl, Binja.
I wonder in the like because it took her this much of time to come to A&E, if anything was done in those 4 hours or so.
Okay, so I got 3 p.m. I got 7 p.m. I won't say the words that's coming in my head. I wonder what was happening in between that. Okay? 3 p.m. to 7 p.m. We would like to take a closer history as to find out what was the issue. Anything else being here? So this is the management in A&E. So what do you think of face mask 5 liters?
Maybe it's wrong.
Would it be? Yeah, so that was not in my reflection. Why must you all use face mask? I hate face mask. I hate using too much oxygen because it masks the hypoxia. Because for you all, once you all see 95 and above, you all are happy. But you all actually don't see the numbers behind how much of oxygen you need. And majority of asthma only need 1 to 2 liters. Once you need 3 liters, there is something wrong. You must just think that this is an airway problem. So the more oxygen you need, the more airway obstruction there is. So it's not about giving oxygen, but it's actually about relieving the airway obstruction. Yeah. So this 5 liters is really not necessary for somebody with 94%. And I know sometimes in like pals and all that, there's you said 10 liters of I don't know but really most of them, especially with these are moderate, should be just given to me. Anything else? Next girl.
After we give the NET, ABN, we have can reassess prior to admission to ABN.
Okay, so let's talk about this admission. You got?
And 12 midnight. How we assess?
5 hours. What are they doing for 5 hours? And from your going through the notes, nothing was given.
From going through the notes?
From going to the notes and the cardex, nothing was given. Or was it given as MDI 12 2 hours?
No, that was not.
Not even
that was
given.
EDs. That wasn't EDs.
That wasn't given.
Yeah.
Okay. Okay. Anything else? Okay. So there's a problem here with the time. There's a problem with God only knows what has happened in between. Nowadays, I cannot seem to trail back. I have to ask the person only, then only I know exactly what's being done. Anything else? Next girl. Why you need hydrocod? Do I need hydrocod? Do I need IV hydrocod? What is the rationale for using IV hydrocod? When to use IV hydrocod?
Really?
Huh?
Really?
Okay. So that means that you must first try your dose first. You must first try your oral dose first. Then only if they vomit, then only. In fact, okay, then never mind. You all will say you all will use IV hydrocod. And I know nobody ever tries. All of you are very simple for you all. So easy. You all just use it and then put the IV line. But the rationale is that there's no rationale for this. Okay. Anything else? Why very dual 4 hourly, 4 hourly? Is that what you all normally do? No, right? Right? Okay. And later on, I will actually allude to this. Okay. So this is for. So the first, I think, most poignant part about this is the time and the management aim. Okay. So this case, there was a huge time lag at 2 levels. Okay. And we have no idea what happened in A&E, and it seems as if from his review of the notes, this patient was just given 1 step nap, and then after that sent to the ward, and this nap was given not by the A&E staff, but it's actually by our own staff, by our own PEDS doctors in A&E. Am I right? Yeah, right. Not even the same. Okay. Okay. So he's going to have his reflection.
Okay, so let's see what could have been done better. So MDS, what should have been done is, given that she's a moderate exacerbation, we can give MDI salbutamol 0.5 puff per kg every 10 minutes times 3, and then we reassess back. We give 3 cycles. We consider to move to severe if, let's say,
so consider 3 cycles lah. So knowing that in moderate asthma, right, you can actually give 3 cycles. That means that you reassess, give 1 more. Still not better. So what is the time period you think that we should reassess?
Within 15 minutes?
15 minutes, 30 minutes. I think appropriate time will be 30 minutes after this. The nurse will give, right? Okay, then you assess half an hour later. Still not better, meaning saturation and saturation, recession. Not happy, give another cycle. Okay, and the cycle, assess half an hour later. And the cycle, assess half an hour later. Still having recession, still having let's say inability to talk in sentences. That means not better, has not moved into what you can actually put into severe zone. Okay, severe zone means that she's actually mostly, and then they later on, and however, if she has responded. So let's say you gave her this, let's say you gave her 0.5 every 10 minutes for one cycle, and she's very good. Okay, things like this one. Okay, they gave her one step. This one is supposed to be equivalent to 2.3. Okay, so this is equivalent to this times 3. Let's say they gave one and she's very well. You cannot go and put 2 hourly, 3 hourly, 4 hourly, 5 hourly. You still must put minimum for yours, just put hourly. You cannot go wrong by putting hourly. You cannot say I'm supposed to eat. And you must remember that this is the third. So when you use ventilator, you have a previous history of it. So all the radar must come. Right? This is the back, and yet they until the front of the. So minimum you are going to put is for and there are half hourly. Since we are going to this one, reflection.
There is another one more. So, why was this is the 5 hours gap? So it's our role to push, and for any medication, it is also our role to make sure it's given, especially when there's a referral from A&E to ward.
Okay, so normally what happens is that from A&E they will call you. I have a case. First question: from what time has this patient been there? Okay, because you know in A&E sometimes they're very rushed, they may not be able to monitor from what time the patient has been there. Oh, patient has been there from 7 o'clock. Huh? You calling me only now at 10 o'clock? What have you done? Nothing. Please do this. So that is your role. Your role, because if you have a role here and you have a role as the person that takes the patient. And your role is to ensure, like he said, the medication is given, and your role is to ensure, okay, I will make sure that there's a bed for you waiting. I'll push the nurses now. You push it down, I will tell the nurses to make a bed or whatever. So this is your role. So that when they come up to the ward, you all can sleep at 1 o'clock. And not when the patient come at 12 o'clock, you all will sleep at 3 o'clock, 4 o'clock, 5 o'clock, 6 o'clock. Right? So the earlier the patient comes, the more stable the patient is, rather than waiting in A&E where they're not giving anything. If really you don't have bed, again, it is your role to say, please give hourly. If tabole, you give half hourly. If tabole, then you better go into your severe pathway, and then we will talk about the severe pathway later on. Okay, this one I already mentioned, isn't it? Why hydrocortisone and why Verital, which is only severe. Okay, so next.
Okay, so this is the assessment of severity of acute exacerbation of asthma. So the parameters are breathlessness, whether the patient can talk in sentences, phrases, words, or if he is unable to speak. How alert is the child, the respiratory rate, the accessory muscle usage and retraction, any wheeze, the SpO2 monitoring, pulse rate, and peak expiratory flow rate. So
Okay. So what would you say?
So
So just remember that they may be like this, they may be like this, they may be like this. Okay, I'm just putting for example. Okay, so what will be the classification? Severe. Yeah. So as long as they fulfill any one of this, they become this this category. It's not that you must fulfill everything for you to be in this category. Sometimes you all don't assess properly. But I find the best is saturation, because saturation does not require clinical skills. Okay, saturation is a monitor AI. That's why the machine will tell you whether or not. So I would use this, and that is why it's very important for you all to take the saturation without oxygen. Ask the nurse what is the saturation without oxygen. and you cannot go wrong by classifying where the patient is going to be. So for this girl, she was here, right? Okay. Yeah. Okay, never mind. We just use this, I think.
Okay.
So this is very important for you all to know, because if you don't know that, then you cannot learn how to use the paradigm. Okay. There's the other score that I use. Okay. The reason why I put this score up was because in our asthma guideline, in our Malaysian asthma guideline, which I don't know when they want to produce out this. Am I? Okay. They were initially using the PAS score. And the PAS score is actually something that you just key in. Can you put the next slide? That it uses respiratory rate, saturation on air, present respiration, and how they speak, and then it comes up to this category now. Okay, so in my algorithm, I actually put this for you all so that you all can assess at every time. Okay, easy for you all to assess at every time, and then you can decide. So basically, if the patient is not at mild and the patient is still at moderate or severe, means you still have to upgrade. Meaning the PAS score is anything between 8 and 15, you know patient is actually not well. So you can use the initial PAS score to decide on the initial severity, okay, or you can still just use the normal severity score that we use. And then the PAS score can also be used in between. So the beauty of the PAS score is the PAS score, if it's 8 and above, you have to upgrade. You have to upgrade. Am I right? So you all understand where I'm going? Because the PAS score can be used to decide where is the asthma severity on the top. And the PAS score can also decide is at the 30 minutes when I assess the patient, which means also you have to take off the oxygen. You have to take out the oxygen for at least 10 minutes, 5 minutes, 10 minutes, and see what the saturation is, and then decide what is the PAS score. Oh, this patient is still not well, still need to continue, still need to upgrade, still need to treat that basically. Okay, so this is what I have in A&E. Am I right now?
Yes.
It is there, right? Okay. So over here, I put the mild or PAS score, moderate or PAS score, and severe, which is lower down. Okay, if it's lower down, I'll show you the effect on the next page if I'm not okay. So in any form of mild asthma, which is the thing that you all know, 0.5 puff every 10 minutes times 3. So this is one cycle. This one cycle is equal to 1 nap. Okay, in your head, remember, this one cycle is equal to 1 nap. Believe me when I say the total dose of salbutamol in this one cycle will always be less than your 1 nap. Okay, because your 1 nap will use 5 milligram. Even for this girl, when I back calculate 12, okay, you times 3, still becomes 3.6 milligram. So what I'm trying to tell you all is don't be frightened. You all get very frightened. Oh, it's only 100 microgram for 1 puff. Your nap is 5 milligram. Okay, so don't be frightened to use, and the max is actually 12 puffs. Some people, adults, will use all the way up to 20 puffs. Okay, and there are studies to show 20 puffs in children also doesn't cause as much tachycardia as 1 nap. Okay, so this is one cycle. So in the mild asthma, of course, we will give the prednisolone. So I put down the prednisolone. There's always a maximum dosage, and we use conservative numbers are 1 to 1.5. So this one is review 15 minutes after every last cycle or at the end of the cycle. So let the cycle finish. By 15 minutes, you review and then you decide how your patient is. Obviously, if the patient is a mild patient, most of the time they can be discharged. And in the mild zone, normally by 2 or maybe by the 3rd cycle, some of them can actually be discharged. I know originally when I made this, it's only supposed to be 2 cycles. That means that by the time you use the 3rd cycle, you have to consider admission. So the aim is, let's say you think that this is a truly mild patient. The patient came with a mild asthma. You still want to give the 3rd dose because it's the middle of the night. I think it's still okay, and then you balik rumah. But remember that At the end of that cycle, you must review after 1 hour. Because you cannot review after 15 minutes and send the patient home immediately. You must review after 1 hour, let the patient sit there, review after 1 hour, patient is still okay, then only you leave. Especially if you're going to use 3 cycles, because this is the routine that we do. Any of you all use more than 3 times before your send home? Never? Never? Okay, I'm just wondering what the success rate is. I'm not sure. But in my head, I'm saying it's about 3. Now, once you use 3, by 2 you can send home. Is it? I don't know. Okay, yeah. So this one cycle. Okay. So the problem is moderate. Moderate, we know minimum these fellas are going to need will be 3 cycles. Okay. So what is aimed here is to say, okay, first of all, they will need a little bit of oxygen. But look how much oxygen I use, 1 to 2 liters only. So use small doses so that you do not mask deterioration. You do not mask the worsening of the patient's distress because you've given 10 liters of oxygen or 5 liters of oxygen. You only give them conservative numbers. Then, and I purposely use nasal prong. Why do I use nasal prong? Because I can use nasal prong and I can use my spacer, right? The nasal prong is here. So ask them to breathe in and out through their mouth. Even small children, don't worry, they will still be able to breathe. Okay, so you use the oxygen and then you use the NBI here. So that's why I use nasal prong when I'm giving NBI rather than face mask. Because if you use face mask, then you are giving the NBI, driving the NBI without any oxygen. So start off with nasal prong for your oxygen delivery. Understand? Okay. So in the moderate asthma, minimum you are going to need is 3. Okay. So moderate asthma kind of like continuous period is 3. Now, if they are still not improving, moderate asthma, usually I would say please admit. Because, and especially even if they've been under my clinic, I want to know why you are coming in with moderate asthma exacerbation. There's always something wrong. You are not taking your medication, you have defaulted me. You know, there's something wrong that I want to solve in the ward before I send you home. But I don't want you all to just send home. The patient will just keep coming like that, which is not the aim of the game. Okay, but if you think that you have seen a patient with moderate asthma and your history, the compliance is good and everything is good and this parent is dependable and the patient responded very well after 3 or 4 and you want to send home and the patient is very well after 1 hour, you still can send home. But you have got to be sure of these things, right? Asthma control is otherwise good. This is a once-off. He is coming to my clinic. He is already on ICS. And the parents are dependable and reliable. If any one of these things are iffy and you want to admit, please write down there. Then I will say, who is this that admitted? Then you will tell me, oh, Prof, admitted because of this. Then I'll say, okay. Understand? Yeah? Okay? So this is the moderate asthma. Okay, any questions? Any questions? Yes.
The mask is not fully seal the mouth and the.
No, you just do it the best as you can. Okay, you don't have to worry. I mean, this is not a vacuum situation or anything. Just as long as you put on the cup. But because you need to give the oxygen. If you don't give the oxygen, how? This is moderate asthma. And it can become very hypoxic. And I have to admit that the MDI takes a bit of time. Right? It takes a bit of time. So you need the oxygen. You cannot give without oxygen. Yes? Okay? Okay. Then we come to severe asthma. So severe asthma will be a patient who is in moderate asthma, who doesn't respond to the 3, then they become severe asthma. So I will have to go back to the next slide. But never mind now. Okay, I will come back to this later on. Okay, so this is the severe asthma. Okay, this is the severe and life-threatening asthma. And the reason why we wrote this up is because this was at the time whereby we were in COVID and we couldn't use nebulized asthma, nebulized ventilators. So please read. Severe life-threatening asthma, continuous oxygen monitoring, heart and respiratory rate monitoring and assessment. So this is the top line. Please do this. Next, still give oxygen via nasal prong at 3 liters per minute. Please remember that every word that was written in this algorithm was deeply thought before every word was Okay, to many people I went before we wrote this down. Okay, so these 3 liters. Next, after initial assessment, choose inhaled therapy. This is one type of inhaled therapy. This is another type of inhaled therapy. Okay, in case you all don't understand. So if you assess and you think that the patient is life-threatening, so go back to life-threatening. Life-threatening. Okay. Life-threatening is unable to speak, drowsy, confused, poor respiratory effort, paradoxical breathing, silent chest, cyanosis, bradycardia, or unable to perform. Again, remember, I only need one to become life-threatening. I do not need all. Okay, some people at least all are, I just choose, you just need one. Okay, so let's move back to that. So if you have life-threatening asthma, you still need to do this and this. If you have severe asthma, you do this and this. Okay. After initial assessment, choose inhaled therapy, and proceed to next step. Because inhaled therapy is always the first thing that you do before you go to this. Comprende? Okay. So we go to severe asthma. Okay. So severe asthma is anybody that is not life-threatening, like we want to say that. So we chose 10 puff plus river. And this is actually based on literature. What people have shown is that ipratropium bromide works well. It actually works more for severe asthma rather than moderate or mild asthma. So that's why we only use ipratropium bromide in the severe asthma. Okay, and Berodual has got formoterol, and ipratropium. Unfortunately, I do not have ipratropium by itself. So I use the formoterol. So it's just formoterol is 1 dose, I think 40 microgram, and the ipratropium bromide is 1 to 5. Okay, so that's why this became 10, not 12, but automatically when you add the two together, it becomes 12, 14. Okay, that's how the math was done. Anyway, 10 puff plus Berodual, I give you 2 puff or 4 puff every 10 minutes and 3. So this is actually 1 nap. 1 nap. Okay, so this is actually 1 nap. That means 1, 1, 1. That is 1 cycle. Okay, we go down. Okay, so you give 1 cycle. Then you do the PAS score. So again, PAS score is actually good if you are going to assess later on. Assess later on every 15 minutes, every 30 minutes, in case if you are not really sure. Okay, so if the PAS score is improving, you can do half hourly. I put half to 1 hourly, depending on you. And then the Berodual will be 4 hourly. But if the fellow is not improving, okay, not improving, your PAS score is still not is still very high, then you repeat box A minimum of 3 cycles before considering salbutamol. So go back to box A, this. So like technically it's 1 nap, 2 nap, 3 nap. Right now? So it's times 3 is 1. Another times 3 is 2. Another times 3 is 3. So for you all in your head, because you all only know nebulizer. Okay, that means it's back-to-back nebulizer. This is back-to-back nebulizer. This is considered back-to-back nebulizer. 1, 2, 3. Now once you do this, can you go down? Okay, once you do this and you assess and the PAS score is still not coming down, single dose intravenous salbutamol, 15 microgram per kilo, max 250 in 10 ml saline over 20 minutes. Okay, please follow. Again, this one was carefully written before because we discussed. That's why these are all the people that were involved when we wrote this up. Okay, so we decided the dose, should we give, should we not give, should we give, and of course this was based on the fact that they're using NPI. So we decided the toxicity was going to be very low because we're not giving them, we're only giving NPI. So single dose of intravenous, continued MDI still every 10 minutes. So that means that you not only give the what do you call it, the single dose of your salbutamol, but you actually still continue your yes, you still continue your MDI lah. Okay, you still continue. So we put down there, if not improving, CO2 rising. So this is 10 minutes only, no? So that means another one more cycle, 4 cycle. I give one bolus dose of salbutamol. I give one more cycle. 10 minutes, 15 minutes, 15 minutes you review. Still not improving, 15 minutes at the end of therapy. Still not improving, you are going to do this. 1 milligram solution at 0.06 to 0.3 milligram per kilo power per kilogram. So you normally I start at 1. Some people may start at 2. Apalah yang mau buat lah. Tapi don't start at 5 lah. Because the technically be too high. So you start at 1, 2. Watch out for hypokalemia, hyperglycemia, and ketosis. Okay. Now I am telling you, if you follow this paradigm or this algorithm like an idiot, you won't go wrong. Okay, so I'm telling you that because a lot of thought went into this. So I was giving an example of how you all do MCQ question. When you first do the MCQ question, you will actually not get it right. Then you sit down, then you look at the question, we think maybe it could be this, maybe it could be that, and then you will get the answer wrong. Okay, so I'm asking you all to follow. Just follow. You cannot go wrong unless you assess wrongly. So again, why I wanted the passport, because the passport requires very little self-listening, but you have to look at sessions, etc. But it will help you to decide whether or not the patient is getting better or not. Can you just go on? Okay, so this is the inhaled therapy, because I think a lot of you all may not understand this. So that's why I need to explain to you all. Now please remember that whether you take this or you take this, once you have decided that this patient is severe or life-threatening, you must do this. It does not say if you assess this patient okay, not okay, then only you do this. No, it doesn't say, right? What does it say? After addition, choose inhaled therapy and proceed to here. So to IV, so for all patients with severe life-threatening asthma, while inhaled therapy is in progress, establish and could if possible also. And you can put either one, because you know what? Whether you give either one also don't make no difference. Okay? So that's why I don't care whether you give oral prednisolone or what. It doesn't make a difference. You all know, right? Whether you give IV hydrocot, oral hydrocot, oral prednisolone, IV pentalpred, IV dexa, oral dexa, it's all the same. They all take 3 hours for maximum. Only difference is Pulmicort, net Pulmicort, which I didn't add inside here because it's expensive. It's something that you can use in ICU, but not here. This was meant for treatment in A&E. Okay, so it doesn't make a difference whether you give oral or IV. It's still going to take 1 to 3 hours to work. So don't. I mean, I that's my point of why you want to do IV. But anyways, and single dose of magnesium sulfate. 50% solution, this is what they have, 0.1 ml, maximum 220 ml, 30 minutes. Okay, and I purposely put this down because I know all of you are takut betul-betul. Ayo, give magnesium sulfate, how lah, hypotension lah, this. So I put this down and I purposely put over 30 minutes. So you all know it's an infusion. If you all are scared, give 1 hour also can also, no problem. Okay, but give an IV bolus. This I find actually very useful because sometimes a lot of the chest X-rays you see are very hyperinflated with a very small cardiac shadow. So that means there is a lot of air trapping, there's a very reduced backflow input. So you give them one bolus. That's why the use of the 2 hand. One is for the bolus, the 10 ml per kilo, because you all are so scared to give magnesium sulfate, and the other is to give your magnesium. Okay, so remember, severe life-threatening asthma. What was my initial assessment of asthma? Okay, this is whether I follow this. No need to think, just follow. Okay. Now, if you have a life-threatening asthma, what do you do? Nebulize this one, you back to back lah. You say you can give your oxygen 10 to 15, you consult your specialist, you prepare the intubation, you consider NIV, but must monitor CO2. Reason why we say this is because a lot of patients, they all go sleeping, and this life threatening will be developed and predicting, lah, you tak boleh guna NIV lah, you mesti intubate already lah, means ICU and chest X-ray. So once you have identified the patient is life threatening, this must be done immediately. If it's severe, this must be done immediately. This must be done immediately. There is no if, but, whatever. Okay, next one. Can you go next? So for severe and life-threatening, severe and life-threatening is not in this paradigm because this is meant for animals for you all to manage. This is when the specialist comes down and has to sort it out herself, what she's going to do. Okay, whether you're going to give net, whether you're going to give IV bolus infusion, IV magnesium sulfate, etc. Okay, now please remember, Barrel dual. When I use Barrel dual, I can continue continuous use up to 3 hours, not 3 doses. 3 hours, not 3 doses. Okay, so you look up. That's why this one says what? 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Okay, right? So remember 1, 2, 3, 4, up to 3 hours. If I my reference for this, I know there's a reference for this one. Okay, I didn't go to reference, but there's a reference for this. It's not up to 3 doses. That means don't be scared just because I gave 3 doses, I have to stop. You can continue 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Because it's very good. The dose of ciprofloxacin pharma is very small. And you can see the dose is tiny. I think it's 40, something like that. It's a ridiculous dose, but it's small. Okay, so and because it's inhaled therapy, systemic absorption is low. What you all don't understand is inhaled therapy and nebulized therapy, systemic absorption is totally different. Right? Okay, so you don't have to worry, you just continue. Anyways.
I know it's written there like concurrent when we are giving the anti-asthma for the severe pathway, we have to prepare for max up. So, but is it okay like we assess after 3 cycles of salbutamol and then decide to give the max up?
I don't want you all to do that anymore.
So concurrent we give.
The original this thing when we made this is please be concurrent. Because as far as you go and read the literature of magnesium sulfate, it's a very safe drug. What do you think of magnesium sulfate is just sitting down there in your research study? Why is your salbutamol there? Why is your phenytoin not there? Why is your potassium not there? Because magnesium sulfate is a very safe drug. It's just that you all get very scared and you all don't want to take it.
Magnesium sulfate and salbutamol, which one should?
The one I'm coming to next. Okay.
Okay, so I proceed with the
So now we
case.
already know the paradigm, so you can go into, she's in the ward. Okay, carry on.
Okay, so upon admission to ward at 12 a.m., she was reviewed. At that time, she was comfortable and it's from 2 liters per minute. She was not tachypneic, there was no recession. She was able to speak in full sentences. Appears actually quite comfortable and it's around 2 liters per minute, but the RR was slightly tachypneic for her age, which is about 25. Her SP2 was
What
100.
do you expect for her age?
20.
Yeah, less than 18, 20, less than 20. Yeah. So she is tachypneic, okay?
Her heart rate was 118. Others the BP was okay, 118 over 65. Lungs still had generalized bronchi with prolonged expiratory phase. Overall good air entry. Treated as moderate AEBA secondary to bronchopneumonia because the chest X-ray was showing changes over the right lower zone. CRP was 16, YSECOM was 17, neutrophil predominant. And she had hypokalemia, which is potassium was 3. So we started her, she was already on drip, we just added potassium into the drip.
So what do you think? Can you say that?
Yeah.
Okay, so this is the management. Oh, sorry, you want to read the management? Okay.
Nasal from 2 liters per minute. MDI salbutamol 12 puff 2 hourly. Brodwal 2 puff 4 hourly. IV hydrocot, QID. Started on ampicillin and azithromycin. Serotype was her home medication, and then the IV drip. So,
Okay. So what? No lah, don't say lah.
sorry.
Okay, the man you put it in. Okay, so what do you think, Wendy? What do you think maybe we can change a little bit here? So everything looks kind of good, right? Okay, maybe this is not that great. Okay, she's tachycardia. Okay, so some of you all are going to say tachycardia is from my Ventolin. So that's a little bit hard to assess. So you have to make you have to decide. But they think the overall entry is a good bed sound. So they put on 2 hourly. What do you think? Nasopharm 2 liters of oxygen. You think okay or not okay? What do you think? Okay lah. I leave it 1 to 2 is not too bad. Salbutamol 12 up hourly. What do you think? Yeah. So generalized bronchi 12 o'clock in the morning. This is what I call the bewitching hour. Between 12 to 3, 4 o'clock in the morning, all things will go wrong. Nurses are sleepy, doctors are sleepy, patients are sleepy, mothers are sleepy. Nobody's going to tell you when it is wrong. So, put away. Again, because for this patient, we know that it just came up, right? So, I would have preferred. Next, what do you think? Why suddenly became too far for our lead? Okay, so even the dose is wrong, right? Right, supposed to be forward. Okay, anything else? Am I will continue? So bring a box.
Since there was some moderate exacerbation, we should have kept hourly.
At least for 3 hours. So this is how I want you to manage in the ward also. If a patient comes up, right, you also don't have a very good gauge of how good this patient is, not good hour. Same thing as this. You're not going to kill yourself, you're not going to kill the patient if you keep it hourly. Just keep hourly for at least for the first 3 hours. Again, bewitching hour. That's very difficult to monitor. And then you can also use peak flow. So I ask you to use peak flow. I again ask you to use peak flow because it is an easy assessment. It is an easy assessment that doesn't require listening to many things. Just do the peak flow and decide. Because if the patient's peak flow, both pre and post, either one is less than 50%, then you know this patient is actually not doing well. And I also told him, I said, these are adolescents. Okay, they will only turn blue, then they will tell you I got Susana. Otherwise you won't actually be able to assess their symptoms. Very difficult to assess adolescent asthma symptoms. That's why most deaths happen in adolescent and young adults. They have difficulty, they have a very high tolerance. Okay? So you use your peak flow to decide is this patient good or not good. I know it's 12 o'clock in the morning, God only knows whether she's actually going to do it or not. But the minimum, if you do this, it helps you. And of course, no need the parallel because we all assess as a moderate asthma. Right? Okay? And maybe the dose is more. And any questions for you all? So I want you all to use peak flow. I know my word is peak flow. Okay? A big patient, it is a big flow with a big mouth. Small patient is a big flow with a small mouth. Don't give small patients big. Okay, and I would say roughly, like this is a 14-year-old girl. Roughly by about 9, 10 years old, most of the patients already know how to do. If you try, patient cannot do, there's no problem. Okay.
This was the chest X-ray. So the opacity seen over here, over the right lower zone, was not there previously. So this is a FBC, this is her electrolyzer, so the potassium was low.
So I'm not very happy with the potassium now. So clearly that means we didn't, once you start giving Ventolin also, you should have already started a drip with, again, you all are very scared of adding potassium into a drip. Just back calculate and then you will know what is your danger level. What is your danger level for giving, what is the potassium infusion danger level? There's a calculation for how many millimole per kilo per hour you shouldn't go beyond. So she says 0.2. 0.4. You? Huh? 0.2, okay lah. Everybody trust Wendy lah. Okay, but in general, it is whatever it is, you cannot go beyond 0.4 millimole below per hour. Okay, so once you back calculate the amount of potassium you're giving, then you know you cannot go wrong. So that you, like these big fellas are just throwing 2 grams in a pint, and then you calculate your filter maintenance. Sure, no problem one. Okay, so this is too low. So you all have not corrected the thing. Okay, next.
So we saw her back again at about 3 a.m. At that time, she had chesty cough and she appeared more breathless. RR was 34. SpO2 under nasal prong 2 liter was 93. Her lungs was poor air entry bilaterally with inspiratory and expiratory bronchi. We gave salbutamol 10 puff times 3 back to back and embryobulbar 4 puff stat. Given NEP 3 pacine for airway clearance, and she has the underlying bronchiectasis. And upon reassessment, air entry and bronchi improved after the airway clearance. SpO2 picked up to 98% under nasal prong. Heart rate was 130.
So what has happened to here? So before at 12 o'clock, we all thought everything was hunky-dory and put her on 2 hourly. Then she didn't become hunky-dory at 3 o'clock because she was undertreated, right? Then you have to, so when they gave, of course, this should have been 12 o'clock, which is something that we said. Why so scared between 10 and 12? So should have been given 12 o'clock times 3, okay? And you give the Beradol together. Give the Beradol together, yes? So you can actually give, if you wanted, you can give 12 puff times 3, Beradol 4 puff. So 10 puff, 4 puff, 10 puff, 4 puff, 10 puff, 4 puff. You understand? Yes, huh? Like a severe.
Yeah, but you mentioned earlier the Beradol cannot go more than times 3, the 3 hour, right? So what if we have
3 hours of treatment.
Yeah, 3 hours of treatment.
Treatment continuously with care.
What if we have already given the 3 hours?
How is it? Yeah, no, can. It's not about 3 hours of cumulative. It's about I can use continuous Beradol for 3 hours. Do you understand? So if I can use continuous Beradol, because if you look at the cycle is every 10 minutes, 10 minutes, 10 minutes. Yes, it is not that I gave one dose here, 3 hours later I give can. So for each cycle, if you look at each cycle takes about 30 minutes. So that means how many times you can use? 6 times? So you can use Beradol back to back 6 times. Okay? Okay, so she treats it and then she improves. Okay, then after that they say 10 puff hourly, Beradol 4 puff hourly, 7 times. Okay, so what is our learning point from here?
So we can start airway clearance, but not with net salbutamol, not with hypertonic saline because it's irritant. It might cause more bronchospasm.
Yeah. So even though this is a patient with bronchiectasis, you have to be careful of your NEP 3%. Some of them of my patients may be 5%, maybe 3%. They may have dual disease. But if they come in with this type of thinking, expiratory bronchi very clear, okay, just use nebulized normal saline if you want for having stay away from 3% or 5%. Okay, and I think the same thing we said is close assessment with the peak flow, so that you actually monitor. So I wanted peak flow here. So you can actually monitor your patient hourly, and of course again this will be 12, and you put your peak flow, because peak flow pre and post. Okay, so that you can monitor your patient. Okay. Okay, so this is what should be done. 12 puff every 10 minutes, the 4 puff of the Beradol back to back, as I mentioned. Okay, don't give antibiotic first, monitor after the first cycle. If not over 50%, give another cycle. That means that once I've given this, they could have also done the peak flow after this first cycle and see how the patient is. If the patient is still actually not good, you can actually repeat the cycle again. So we use 50% of best peak flow. Right, so when you go through the notes, you find the best patient's best peak flow, and anything less than 50% of this means that the patient is already in the severe zone. You need to repeat this and again and repeat this, as opposed to just giving the patient as hourly. You all understand? You understand? Yeah, use the peak flow. After a certain treatment, you can use the peak flow.
So at about 6 a.m., we Went to see her again. She appears to be in another bout of bronchospasm. SpO2 was fluctuating 92, 93, best was 94, 96 under the same nasal prong 2 liter. Heart rate was more tachycardic, 135. Although she was still alert, tachypneic, RR was 30, unable to speak in sentences with subcostal recession. Lungs was poor air entry with inspiratory and expiratory bronchi. We tried MDS salbutamol 10 puff stat and noted that there was improved expiratory bronchi and prolonged expiratory phase, but she still appeared breathless. And there was inspiratory bronchi as well. So at this point, we were thinking maybe the bronchiectasis is, we were thinking maybe there's a bit of underlying secretion with plugging because of the underlying bronchiectasis. So we started CPAP, PEEP8, FiO2 25. CBG at that time was CO2 was 32.
So why do I do CBG? What is the aim of doing the protect? 30 acidosis, what will be the why? And if I see the 30 acidosis, what do you worry about? Huh? Yeah, so it means patient is very tired. Basically, this means if the this is a low CO2, so this girl actually wasn't very tired yet. She hasn't decompensated yet. But younger ones they decompensate. They're tired. So once you have high CO2, you are in trouble already, right? This patient either needs to go to what do you call it, ICU. So it's very important to use this. So okay. You want to read this and then I just...
Okay, upon reassessment, after starting her on CPAP, actually the breathless improved. Inspiratory bronchi was resolved. RR came down to 16. SpO2 was 98 under the CPAP. Heart rate was 108. Lungs actually good air entry with resolved inspiratory bronchi and minimal expiratory bronchi. Plan was to keep the CPAP PEEP8 FiO2 25, salbutamol 10 puff hourly, and Brodol 4 puff 4 hourly. IV hydrocort was already on board. Napsaline 3% QID with Serotype 25 1 to 5, so own medication. So this was the plan at 6 a.m.
Okay, what do you all think? How many times has this fellow been disturbed? From 12 o'clock, 3 o'clock to 6 o'clock. So, at which point would you have added medicine something? Yeah. At 3 o'clock, actually, already she has become not a desensitization of asthma. So at this point, already you can have added magnesium sulfate. If you add magnesium sulfate here, you would have probably slept. Patient would have slept and you would have slept. Okay? So again, because you got a low saturation. Once you get a low saturation already at this, and patient has already been given. I mean, you know, if sometimes what I do is I play the cycle. I just keep on giving the cycle. I should like to keep my ventilate just continue back to back. But you know, if I know again, you know, very difficult. People are not awake and sleep and all that. So you can actually keep your magnesium sulfate here. So what's your dose of magnesium sulfate you want to get for?
15.
Okay, next. Okay, so I think there's the end, isn't it? So I think there's the end, yeah? Okay?
So here, yeah.
Okay, diet is and that's it, use. Okay, next. Okay. Last month, mom had in A&E, hey, saturation is 80%, you know. Did you all know? Did you know that the saturation was 80%? Did anybody tell you? Why you think nobody told you? Huh? Tell me why you think nobody told you. Because you never asked. So let's remember, must ask. It is documented there. Nurse has documented there. Don't know whether she knows the doctor or not. I have no freaking clue. Put 10 liters of face mask oxygen, 97%, everybody is happy. But she came in with 80%. And her mother has been doing this already. This is a sign your patient is not well. The misty salbutamol in itself may not work. Because I don't know, I must go check technique or this nonsense, but nobody has the time to do that, right? Sometimes you must say, 2 hours. When did you last give? How did you give? And really, if the patient mother has been giving correctly, means you're dead, man. You're tomorrow, you're not going to work, man. Okay? So, accent pressant. What is the asthma classification? Yeah. Okay. And if you're, and because I'm an idiot, open. I am an idiot, I will follow this. What do I say? Do this, do this, do this, do this, do this. Immediately. Okay? Do this, do this, do this. Now, how many hours are they allowed to stay in? Maximum 2 hours. Your patient was in A&E from 6 o'clock until 9 o'clock. So please remember the patient must be ready to move. That means once you have decided this is life-threatening asthma, the phone call must be made. I have a life-threatening asthma. Find me a bed in ICU. You do not have a life-threatening asthma sitting down in A&E and you're handling. Because it's always very difficult in A&E. It's very nice in ICU. Everybody understands the language. In A&E, it's a freaking torture. So don't torture yourself, don't torture the patient. Patient should be in ICU within the 2 hours. So that's why I don't want you all to think anymore. I want you all to follow. Right? Follow means you put your 2 IV access, you give this, you give the max out, you obviously give this first, give this, don't follow, consult specialist, call ICU, chest X-ray. Follow. Right? When he didn't say do this first, like I'm repeating myself again, I didn't say do this first, assess 15 minutes, do this first, assess 15 minutes, do this first. I didn't say that, I put it all in one. So please follow. Because this one is, like I told you, my aim is, this one was not to teach you how to manage. This one means if you go to ICU to assess by specialists, not for able to manage. Okay, that was my last one, next one. Okay, so what's new in acute asthma? Not so new if you look at the studies, but yeah, okay. Nebulized magnesium sulfate, some of you all may heard of it, but there's no literature to support it. IV magnesium sulfate, yes. So you asked about IVI magnesium sulfate. So there is actually only one or two, I cannot remember now whether one study. 50 milligrams per kilo per hour times 4 at a 10 milligram ml per dilution. So you make the dilution at 10 milligram per ml. This becomes 200 milligram in 4 hours. So this study found that compare this bolus and this, people were discharged more likely when they were done this one. Okay, and they found hardly any side effects. So what they basically say is, when you use magnesium sulfate, your diastolic pressure sometimes can drop a little bit, but they say don't worry. Okay, because it's anyway your diastolic is an automatic diastolic blood pressure. You all know your blood pressure cuff is an optimized or auto-calculated. It's not the patient's true diastolic EVP. Okay, so you can use this. So this might be something that you may want to consider after you give your bolus. Let's say you give your bolus and the bolus doesn't work, then you continue another 3 hours or 2 hours. You can actually do this as a, that means you can give for 4 hours. And what is your magnesium level that you all keep at? Is it less than 2 or something? What is your level? Is it? What does it say in Frankshan? Can you all open your Frankshan? What does it say? There's a level that you all have to monitor, right? I know in ICU you all do continuous, right? You all continuous over Tatalaga, Baushinpa. I cannot find the literature on that. That seems to be something that's unique to Frankshan, but I can at least find the literature for this one. 1.5 to 2. 1.5 to 1.5 to 2.5. That means literally you all have to check like 2 hours, 2 hours. But this one just shows that you only need 4 hours. But some studies are done in a very interesting way because this was meant to discharge with patients. So that's why it's done over 4 hours. That means that there is at least one study that shows that over 4 hours there's better discharge than giving a bolus. So this is one, ipratropium bromide. Remember that ipratropium bromide and nebulized times 3, and then 4 hourly is the way to use ipratropium bromide for your, what you call it, what do you call it? Okay, so this is the way to use. So that's why I give 1, 2, 3, 1, 2, 3, 1, 2, 3. Right, okay? 1 cycle, 2 cycle, 3 cycle. That is the way to use for nebulizer. But we use for total for 3 hours, you can keep on doing, and it's actually quite useful. So NDI is equal to nebulizer. This actually we have proven in our own study, but this is not published. So I got one of my master students to do, and when we transition between nebulizer and NDI, we found that there was actually no increase in admission, because at one time we were wondering whether our paradigm also works out, and we did not show. Dexamethasone versus prednisolone, they have the same output, but it's more palatable. Dexamethasone is more palatable, so hence less risk for vomiting. Okay, so sometimes you can actually use, and I put the dose of the dexamethasone there in the paradigm. Nebulized budesonide is better than oral prednisolone. Okay, maybe in discharging severe asthma and less need for oral steroids. But this is only in severe to moderate asthma. So because of that, we don't use nebulized budesonide, because any severe asthma or moderate severity asthmatic exacerbation should not be discharged. Okay, so coming to, I think I have another slide of Omicron. NIV is definitely, previous one? Sorry, let's go previous. Let me finish up the, NIV is definitely better than high flow. So don't use high flow. High flow, I think, is not, people normally use NIV. You all know, and high flow nasal cannula only washes out dead space, a little bit of people, so not very the same. Okay, some of you all say, if I use IV salbutamol, why should I continue that salbutamol? But people have shown that it definitely will cut down your need for. So you must continue your inhaled therapy. You cannot just give IV alone and not continue your inhaled therapy, because remember that the primary problem is still your airway. Okay, so you should put the two together. Okay, so next one. So Pulmicort, because Pulmicort is something that is new and fancy, the adults use it, and they use it for, you can even use it for moderate to severe asthma. The beauty of Pulmicort is because of its rhythmic configuration, it has immediate action in the lung, as opposed to even your IV hydrocort, it takes 3 hours. So what we know is that it works before the hydrocort works. Okay, so but we find that studies have shown that the remission rate is actually higher, and the need for oral corticosteroids is significantly lower. However, if you compare net Pulmicort versus oral versus no prednisolone. So let's say you take patient, I give you net Pulmicort, or I give you net Pulmicort, no steroid, no Pulmicort. Definitely net Pulmicort is better. But when you compare net Pulmicort and oral steroid, there is no difference. You understand? Yeah. So there's no difference between net Pulmicort compared to oral steroid. But what they find is that the more severe asthma just get a bit better, because I told you that net Pulmicort works faster. But at the time point of 4 hours when you assess them, the net Pulmicort and the oral prednisolone is the same. So sometimes we want to use it so that you can get the patient better faster, rather than, but you still need to use oral prednisolone. It's very expensive. Okay, so many people have used this. They do support this use. No, we have no data to suggest. There are no studies that have been done yet. Maybe when the studies come out, then see. Because this is original budesonide. You cannot take generic budesonide made by Glenmark or Mandela or whatever is made and have the same effect. You are not going to get the same effect. This is original Pulmicort. This is what the data shows up. Okay, so that's why I don't use, but I think maybe you're in ICU, I think it would be maybe useful to use for patient hazard. So again, remember that 4 hours already your steroid can already work. So what is the use of really using using less quantities of peanuts. That's why I don't really know. Very expensive. Okay, next. Okay, so I want to go. I want to do the action plan. Can you show me the action plan? Okay, so please always send an asthmatic back home with an action plan. This is in A and E, and this is in the ward. Please remember, you must always put your name, everything, because I want to know who is the doctor that wrote the wrong action plan. And then put the weight here, so I know how you calculated your MDI. Okay? Now, the most important are these two sections. This is when the patient is having just a URPI. Okay? So the standard dose is 2 puffs 3 times in a day. This is the standard dose. So most of your action plan actually should already have the 2 there printed. This does not change. This is like a prophylactic. I'm stopping you from having a worsening. So this is probably just a URPI. Now, once there are more symptoms, then only we do 0.3 puff per kilo to a maximum of 8 puff. Now, even this maximum of 8 puff, so sometimes Prof. Jessie doesn't like to use 8, she will use 6. And I can understand because some parents don't look as if you can trust them. So I will go to 6. Okay, I never go higher. The more I don't trust you, the more lower I go. So that you are going to come and see me. So remember, it could be 864, 888, apa lagi mama buat, tak ada masalah. Just remember your maximum is 8. At 0.3 puff per kilo, maximum is 8 in the action plan. Do not use 0.5 puff per kilo in the action, even at the emergency zone. So if you calculate this child at 10 kilogram, that means 3 puff, this becomes 3 puff. If this is 6 puff, this becomes 6 puff. Okay, and when you tell them this, with the same breath, I will say, jangan guna 1 jam, 2 jam. Ini tak boleh because that means anak mesti datang ke hospital. Because they will sometimes they get confused. So I will tell them maximum yang terdekat is setiap 4 jam. Tak boleh guna 3 jam, 2 jam, 1 jam. Because people will do that. They will say, Dr. A ni ada buat, kenapa saya tak boleh? My question is, you are the doctor ke? And they don't know that you all are using with oxygen, especially for the moderate asthma. Yeah, okay. So you using, and this is the same thing with the asthma. When I tell them this, I said, jika anak sakit and you tak boleh datang lebih cepat daripada 15 minit, then sahaja you boleh guna 8 puff setiap 15 minit. Tetapi bila datang ke hospital, cakap kepada doktor, doktor, saya ada guna ini setiap 15 minit. Jika almost same jika doktor cakap, kenapa you buat macam ini? I will say, cakap kepada doktor, because anak saya sangat sakit. And there's a reason why. Because after you use 8 puff, 15 minutes and 3, when they come to A&E, it will be clear. Then the doctor is going to discharge that with the So be careful. So you all must learn how to ask the right question. Because some of my patients may be very clever and they use this, then they come to see you, then you all discharge, and then the patient comes back at 3 o'clock in the morning. So that's why it's very important to know what therapy you use at home. Right? What therapy did you use at home will determine how sick your patient is. Because it's all about how the medication is going to work. Yeah, your salbutamol works at least for 6 hours. Comprehending? So do not put 10 puff, 15 puff, all this nonsense I want to say anymore. Yeah, it is maximum of 8 puff. If you go lower, I got no problem. It's when you go higher that I don't know how dangerous this action plan becomes. That's my problem. I don't know how dangerous. Any questions? Any questions? Okay, finish that?
Yeah.
Before that, nothing else, really, huh? That's all I want. Okay, any questions? Oh, okay, I put this down. Okay, because people in Africa have shown that it works. So this is for the child who cannot use. So mouthpiece, we always say between 6 years, by 6 to 8, they should be able to use mouthpiece. Okay, or I put cup or below 5 years last. So you can put the cup. So even though it's not tight, it doesn't matter because some patients may not be able to afford an aero chamber. Now these aero chambers are cheaper. I'm not sure whether your AD has one selling. In those days they didn't have. So I used to have paper cups and said, please use this, but then the next morning, please go and buy a aero chamber. This cannot be used for long term. It doesn't last very long. It's for temporary. This is what they used to do for older children. This actually lasts longer. But the problem is the mouthpiece. Like I said, the mouthpiece must be above 5. Younger children cannot come in. They cannot. Okay, anything else? So this is a possibility to do. Okay, this is just okay. So that's it. Any questions? All understand, huh? Okay, ask me now. Quickly ask me.
What is what you mentioned, the medicine loading dose will be twice before maintenance.
Yeah, medicine loading dose you can give to a maximum of 2 to 3. So some people have given once, after that don't give another. But it's based on this times 4. So I figure that because this literature I just found only. So I figure that this might be a way to go. So if your first dose don't work, then you continue for another 3 hours at your.
But this dose is higher than the fraction dose.
Yeah, so this is actually the study. So Frank Chan, I don't know where he gets his dose from. So that's my problem, you see. I always say that, but at least this one I got literature lah. But you monitor your thing. But you notice this is for 4 hours and then I stop.
Stop straight away, not at all.
Yeah, stop. So it's like a treatment dose. I give you max out to say, how does magnesium sulfate work? Huh? Membrane stabilizer. Membrane stabilizer means what? What membrane am I talking about? Action potential of the muscle by, I know Roshni will know. Roshni know. Keywords not there. So answer tak boleh pakai. How does magnesium sulfate work? Roshni should know. Oh, my other recipe fellows. Okay, ask you, because you already sudah lebih 6 bulan. Not sure. The God. How does how does magnesium sulfate work?
It's a kind of a muscle relaxer.
Muscle relaxed by how?
So dilated.
Yes, obviously. How?
It blocks the calcium, supporting the vessel density.
I use the word competes. It competes with calcium. So when you compete with calcium, you cause muscle dilatation, and it also reduces inflammation as well. It's got a secondary effect by reducing inflammation. So that's how magnesium works. So it competes with calcium to result in dilatation. Okay, so it must at the muscular level. Okay, what's the reason?
Yesterday I encountered one problem is the IBS of the whether I need to dilute or I need to eat.
Okay, so what is the dilution is 500 milligram per meal, isn't it? You go up.
Not salbutamol.
Oh, salbutamol is meat. Yes.
I go to take.
Huh?
Pharmacy said to dilute.
So there is
a delay in the IBS of the
oh, so that's why it was a delay.
Yes.
Not because they didn't have salbutamol lah.
Both issues.
Okay, so let me check this.
And if I can help to start an IV for asthma patient.
Downstairs ah. Okay. Oh no,
They
yeah.
always get a people phobia.
Who?
They always get a high peak for
Yeah.
asthma patients.
So what do you think? You have been in ICU for some time. What do you notice?
Because in asthma patient not only although actually show hyperinflated, but there is a mixture of paralysis and hyper.
No.
So still can.
Why is hypertension from? Yes. Primary pathophysiology is the airway is small. So what do we always use? We use PIP, no? What does PIP do? It opens the X-rays. It states the airway both in inspiration or expiration. So what you will realize is that, or we also started like that as well. We also say auto PIP, la, this, la, that, la. Then we realize they actually get better with higher PIP. They always get better with higher PIP. Don't give phenomenal PIPs of 10 to 12. So we start with conservative PIPs of 8, 9, somewhere around there is actually quite good already. You cannot give them low PIP. You cannot give them 4, 5, all that you go. 6 also pun tak cukup. You need 7, 8, 9, somewhere between them. So I think that pathophysiology is wrong. But like I said, don't go give 10 and then after that later, pneumothorax. Don't give sudden high peak of 10, we don't need again. You start at 7, like 5 or 6 is not enough. 4 definitely detrimental, so you go up slowly. So peak is, you need to give them peak. You find it always works. Give, okay, anything else?
I mean, in the mild cases, you should come with the bronchi and then back to back. That we can use the same principle like mild asthma.
So VEW and MTW. Sorry? Virus-induced wheeze. So if you look at viral-induced wheeze and virus-induced wheeze, MTW versus asthma, it's just the age. Once you have labeled a VEW, okay, you can follow this paradigm. Because technically a VEW is actually asthma. Except that if you normally go do your VEW, let's say you've got a 6 month old baby, you go label VEW, head upside down. Alright, because 6 months without boleh bagi na, don't bagi na ini. Yes, unless you say strong family history of atopy, allergy, food allergy, don't know what. Then maybe I will disturb you. But then you must be careful. So your use of the VEW have to be careful because there are some VEWs that I know that are bad. Okay, but what happens with the VEW is that they may not respond totally to salbutamol. They actually don't reverse totally to salbutamol. So for those, you have to be careful. So your question is right because if you are suddenly making a newly diagnosed VEW, you have to be careful. Now, but still goes back to whether I want to use the magnesium sulfate. Okay, for me, magnesium sulfate is definitely very much safer than high salbutamol. So before you start your high salbutamol, you have to consult. Okay, but for you and your state, you still may need to consult somebody. Anybody with a severe asthma, you are going to need to consult. But this is a severe asthma paradigm. So you need to look at the history and decide, is this somebody who may not even be an asthma? Then I should be using this, then do this. Does that make sense? Yeah, so the history must be very good. Yeah.
The magnesium sulfate,
Which one?
which one's really
I'm going to send you now. Show her. Question is, ask a question. Which one to give first? Magnesium sulfate or salbutamol? Raj, what is the answer?
Salbutamol.
Ask your question again. In what case you must tell?
in a severe
Oh, sorry for myself first.
Go to the scene. Read. Read every word. I tell you, I spend a lot of time doing this. This is a one-man job. But every word has been checked. English has been checked. To make sure that you all understand that it is not misconstrued. Right? So, magnesium sulfate. Don't be scared. You are scared, give 10 ml of saline on the opposite hand, give your magnesium sulfate together. Give the magnesium sulfate over 30 minutes, 40 after Okay, but it's 20 minutes. And then 20 minutes, right? Is it 20 minutes or 30 minutes?
Over 30 minutes.
I was 30 minutes, this is conservative. Most of them will say 20 minutes. Okay? Okay, so any question? Yes, yes.
If you start the IBI sometime, how long can we continue doing the IBI sometime?
Yeah, so according to literature, that I found 4 hours. But I don't use IBS. Oh, sorry. Oh, you're talking about IBS and so all that depends on the patient. So normally once you break the spasm, I will take off my IBS and very quickly, just keep on hourly.
We need to
Overlap what?
MBS sometime or the con.
Yes, because cons currently I am using, go to the, see, wait, hold on. See, single dose, continue MBI salbutamol. So you are continuing this still. Then if you already use your 6 cycle, then you drop the Paradual, you just continue your MBI salbutamol. So you cannot just give IBI salbutamol alone and not use the MBI salbutamol. That's why I repeat, inhaled therapy is most important. Don't depend, because this one will give you side effect after that. Then you will see the tachycardia, like the nausea, you will see all sorts of things will come from the salbutamol. The ketosis, it's very common to get ketosis and acidosis from salbutamol. Okay, so that's why you can take it off as soon as you can.
So when we already have the salbutamol, the concurrent, after we start, can we like shorten the frequency of the salbutamol? Because previously we have already hourly.
Yeah, then you assess your patient. So I always say hourly times 3 assess. 2 hourly times 3 then assess. 3 hourly times 3 then assess. You understand? You need to assess your patient to see whether or not it's okay, but it's hourly always. Does that make sense? Okay? Okay, bye then. For the slide. So from now onwards, cannot make mistakes, huh?